I'd like to introduce Dr. Alexandria Phan. She is currently at Houston Methodist, and I've had the pleasure of seeing her around the world, speaking at ENETS and moderating a panel there in Barcelona just recently, and also at ASCO GI up in San Francisco. And her knowledge is really exemplary with neuroendocrine tumors, particularly in the areas of research and clinic. And we're very fortunate to have her here from Houston today. So please give a warm welcome to Dr. Alexandria Phan.
Actually, it is a pleasure to be here. I'm actually, it's to be in sunny California. I think I've been here several times, but today is very meaningful, and to see the multidisciplinary team of everybody getting involved, and actually people spending Saturday to be here. So I don't want to spend a lot of time talking about things, but I'm going to do my task. My role today is to give an overview of well-differentiated neuroendocrine tumor, and the idea is that to continue this great set of agenda with great speaker. I mean, I think every single speaker you're going to learn a lot from them. Dr. Nissen actually abbreviated his talk, but he's a great, great surgeon and very, very well respected. I'm sure it's a talent that not everybody have. So, let's see. So you already know this, but there's a steady and persistent increase in the incidence of neuroendocrine tumor. The increase is actually steady compared to many other diseases, but especially in gastrointestinal pancreatic neuroendocrine tumor. And there's actually a greater incidence of NET compared to a steady increase of NET compared to other diseases in all. Okay. What it actually tells you is that as people live longer with NET and more people are being diagnosed, the prevalence of neuroendocrine tumor will be increase even more so. This is the disease-specific prevalence in the US in 2004. This is only GI cancer, and you can see that neuroendocrine tumor is second most prevalent GI malignancy in 2004 based on census. So in order to understand what is neuroendocrine tumor, which is actually a very difficult disease to understand because people go around still calling carcinoid tumor, different people call different things, and I think it's the concept of understanding neuroendocrine tumor is very important for you to be able to communicate with your physician and to participate in your own care. Neuroendocrine tumor is classified by many things. One of them is by anatomical origin of the primary site. For example, foregut include neuroendocrine tumor that originate from lung, thymus, stomach, duodenum, and pancreas. And then midgut, small bowel. And then hindgut is essentially transverse, descending colon, and rectum. Then the other way of classifying neuroendocrine tumors is by their proliferative index or by histology. The proliferative index is measured at this moment by ways of Ki-67 and mitotic figure. So for low grade, it's defined as less than 2 mitotic figure, which is, what is mitotic figure? It is essentially looking at the microscope of a smear of a tissue and looking for division within the cells that they're trying to divide. Within each field, they're looking at 10 high power field and average out the mitotic figure. And Ki-67 is a stain, okay, immunohistochemistry stain. So low grade is defined as less than 2 mitosis per 10 high power field and less than 3% Ki-67. And then high grade is, of course, anything greater than 20 or greater than 20% Ki-67. And then intermediate grade is anywhere in between. This is another classification of neuroendocrine tumor by histology. And you can see here there's many different nomenclature by different people. There are traditional, ENET has used the WHO classification, and then NET also had their own version of neuroendocrine tumor. What it boils down is this. Well-differentiated neuroendocrine tumor that is low grade is essentially, traditionally has been known as carcinoid tumor. These are the same name in ENET as well as NET. They're well-differentiated neuroendocrine tumor, low grade or grade 1. Moderately differentiated neuroendocrine tumor are usually atypical carcinoid tumor. They're grade 2 in ENET and they're intermediate grade in NET. And the one that most of us don't see because they're fairly aggressive or poorly differentiated or high-grade neuroendocrine tumor, but they can also be small cell, where the cells of the tumor look very typical small, and these are grade 3 small cell or high-grade neuroendocrine tumor. And the other type is large cell neuroendocrine tumor. These are grade 3 again, but on the slide of the tissue, it looks consistently large cell. These are poorly differentiated. Another way of classifying neuroendocrine tumor is by functionality. So we went and talked to you guys about neuroendocrine tumor being classified by the origin of the primary sites, the histology, and now functionality. Functional neuroendocrine tumor are anything that has hormones, symptoms relating to hormone that is over-secreted. And then non-functional is the absence of hormones-related symptoms. And the reason it's shown here big and small is that 90% of neuroendocrine tumor are non-functional. That means they're fairly silent without hormone-related symptoms. This is survival by stage and histology based on the Cedars data analysis. Within well and moderately differentiated neuroendocrine tumor, you can see that the more advanced the disease, the higher the stage, the survival is decreased. And actually, you can see here, this is local disease, regional disease, and metastatic or distant disease. These classification is actually staging by the Cedars database, not so much as the AJCC staging system. Within poorly differentiated neuroendocrine tumor, stage by stage, they are worse than well-differentiated neuroendocrine tumor. Okay? So here is stratification of survival based on stage and histology. Stage and primary site is also shown here in this slide. Actually, let me just go over. For lung neuroendocrine tumor, localized disease with 5-year expectancy is about 84%. What that means is that if you follow 100 patient, 84 is the median expected at 5 years for localized disease, 72% at 5 years for regional disease, and 27% distant. The point here is that the more advanced the disease, this 5-year survival rate decrease, okay? Remember, these are statistics of other people, they're not yours. You will write your own chapter, and so I don't want you to take this message home and say, oh my God, I don't have 84% or 25%. They are of other people and of statistic, okay? Just remember, you will write that chapter on your own. For pancreatic neuroendocrine tumor, 5 years is also 79%, 62%, and then 27%. Decrease in survival or at 5 years, the more advanced the disease. And the same is true with rectal, okay? And then survival is also stratified by the primary sites. For example, just on this list, you can see there's a grouping of foregut neuroendocrine tumor with being that life expected, 5-year survival rate. And then for midgut neuroendocrine tumor tends to be better as far as 5-year survival rate. And then there's the distal, the hindgut neuroendocrine tumor, okay? So why is this that I've spent this time talking about classification, stage of disease, and prognosis? The reason is the 3 most important determinants of prognosis in neuroendocrine tumor are histology, grade, and differentiation, histology, cancer stage, and site of primary disease. I used to tell my fellow that if I know these 3 things, if you've done your homework and I know these 3 things, I can guide the patient and know their natural course of history and their best treatment 1 or 2 steps ahead of their disease. And that's very important to understand that these are the most important determinants. Clinical presentation, how does neuroendocrine tumor patient present? You guys all know this. You all have experienced all of this. But the point here is that symptoms of neuroendocrine tumor can be vague, and it's usually for example, can be from mass effect relative to the location. Let's say you have enlarged liver, you'll have right upper quadrant pain. They can have symptoms that is related to the classical signs and symptoms of neuroendocrine tumor, diarrhea, flushing. But the bottom line here is diarrhea is a very common symptom. So therefore, these symptoms are ubiquitous, meaning very common. Therefore, they're mistaken for other more common pathology. And hence, the median time to correct diagnosis in neuroendocrine tumor is about 9 years. So just to very quickly, I'm going to try to go through the symptom very quickly because most of you experience this. The most common symptoms of carcinoid syndrome is actually flushing, not diarrhea. The next is diarrhea. These are the classical carcinoid syndrome symptoms. And other symptoms include right side valvular fibrosis, symptoms relating from valvular fibrosis, and then symptoms of bronchial constriction. This is classical carcinoid. There are many variants of carcinoid syndrome. Okay, skin changes that we oftentimes see are these. I actually go around thinking I have carcinoid tumor just because I have these rash on my face. Actually, I become very paranoid with many other things, which is actually good for a GI medical oncologist to be OCD or anal retentive. Carcinoid heart, this is a finding and pathology of carcinoid heart. I'm trying to be quick here. And this is dermatitis, desquamation, and glossitis. These are classic that most people do not experience, but these are classic. So if you have this, I think medical student probably can say, oh, you have this diagnosis. But the problem is this can be related to other things as well. So I think the things, this is migratory erythema and cheilitis that is associated with another syndrome that is called functional pancreatic neuroendocrine tumor, meaning glucagonoma. So the diagnosis of neuroendocrine tumor, many of you guys wonder, why do we miss this diagnosis? The diagnosis of neuroendocrine tumor is made or suggested by symptoms of over-secreted hormone, abnormal elevation of metabolites of serotonin or hormones of the pancreas, such as chromogranin A, radiologic appearance of very hypervascular disease, but the diagnosis of neuroendocrine tumor is made and confirmed by tissue pathology. You need tissue to make the diagnosis of neuroendocrine tumor. Okay. Laboratory evaluation. These are something that my patient asks me all the time. What's the use and what's the clinical relevance of urine 5-HIA 24-hour collection? The problems you have to understand is this is a non-specific test. It can be altered by many things. The level can be affected by food, being on proton pump inhibitor, that's Nexium, Prilosec, and that kind of thing, anti-acid, or you have a small bowel pathology. Even small bowel resection can alter the 5-HIAA. Renal insufficiency can alter that as well. So when do I use urine 5-HIA? I use it when I think there's a high suspicion for midgut neuroendocrine tumor, because it's highly suggestive when 5-HIA is elevated for a midgut neuroendocrine tumor. However, it has poor correlation with the severity of carcinoid syndrome or disease burden, and it actually useful as a prognostic outcome. So if somebody comes in with elevated level, known stage 4, and normal 5-HIA compared to somebody who has normal 5-HIA versus the one that's abnormal, prognostically it's different between those two patients. Another markers, another biomarker or serologic marker that we use is chromogranin A. The problem here is that it's produced by many endocrine organs, and the level is highly sensitive to drugs, again, proton pump inhibitor. So when do we use this? It is not diagnostic of neuroendocrine tumor. It's not always correlative of disease burden. It is, however, a prognostic indicator of disease outcome. So that's useful to know. These two markers that is being ordered needs to be used in that way so that it's in correlation, collaboration with other things, symptoms and radiologic findings. Okay. The most common radiologic evaluation for neuroendocrine tumor, anatomically, you do it by CT scan or MRI. Anatomically, looking for the characteristic of the tumor by CT or MRI. Nuclear imaging is to look for essentially finding the primary sites or other sites that is hard to assess by CT or MRI. And functional imaging, I think that's where the direction of the imaging for neuroendocrine tumor will go, CT PET scan or other type of PET scan. So why do we use imaging at all? I think imaging is very useful to determine cancer stage and primary site. Remember, answering those three prognostic indicators, sites, histology, and disease stage is very, very important. So this is an image of a patient, per se, who comes in with abdominal pain. The first CT scan is just a plain CT scan that ER do all the time. You don't see anything that is abnormal here. It's hard to see, but there's nothing wrong here. But if you do an arterial imaging, that means to a phase of the CT scan, you start seeing a mass here that I try to point out on there. that's right there that could easily be missed. And the venous phase, you also see it again, and the delayed venous actually see a washout. So venous and mass and venous delay show a mass being washed out is very, very characteristic of neuroendocrine tumor. MRI has similar. This is a patient actually that comes in with abdominal pain, and for some reason or another, she got an MRI, okay? This is a standard native MRI. And this is a T1 with contrast. It's another phase of MRI, but you can see the disease is actually extensive if you do T2. So MRI also has to be done right, T2 and T2 with contrast. Octreotide scan is something that is being done in many places in the US only because that's the only modality most of us have as far as nuclear imaging. For example, this patient of ours who had pancreatic resection had years and years of restaging with just imaging alone, CT scan, and completely normal essentially. Nothing. All labs is completely normal. This person would have left our site saying no evidence of disease, but because we alternate imaging between anatomic imaging with CT and nuclear scan, we found that actually she has a recurrence of disease at the retroperitoneum in this area that was previously resected. You can even see suture or clips there from her prior surgery. So this is another curable situation where you can actually, if feasible, resect this sites out. Okay, so I think this is where the future is going. Gallium-68 octreotide PET CT scan, just as an example. This is a CT scan of the liver, normal looking. MRI, starting to see something in the MRI. You can see those two spots that I highlight with the yellow arrow. And then another one maybe pointing another lesion or two more. But what's it's seen on the gallium-68 octreotide PET scan is that there's actually a few more lesions. These information is very important to a liver surgeon like Dr. Nissen to decide where to resect, whether it should be done in combination with radiofrequency ablation or not. So finding accurate information radiologically may not include just CT scan, octreotide scan, or PET scan. It's a combination of all of those, but they're very important to know because diagnostically it helps in your therapeutic management and the line of care or therapy that you need. So cancer staging is something that is just introduced for neuroendocrine tumor in the 2010 version 7. We are writing now the AJCC version 8, and I'm actually lucky enough to be on that committee, so it is a privilege, but it is something that we revise as more information comes about. The first time it came out in 2010, this is a TNM staging system based on the tumor characteristic, T, nodal characteristic, whether you have nodal involvement or not, and metastatic, distant spread or not. It's the first time it's been introduced in NET. There's a few neuroendocrine tumor that's still without TNM staging, but fortunately for GI neuroendocrine tumor or GI pancreatic neuroendocrine tumor, the staging system is there or introduced already. And the grouping, like I said, is based on tumor, nodal, and distant spread. Okay? Here's some general consideration for treatment of neuroendocrine tumor, and I think I say this because my colleagues in other disciplines likes for me to emphasize this. You need a multidisciplinary team. I cannot do this alone, and you cannot do this alone. I need you as well as my other colleague as part of the team in managing your care. Surgical resection is always a consideration. There is always some point in time when you need to assess the surgical resection, whether it's for palliative to control symptoms or for going toward that disease control where you have no evidence of disease to improve your prognosis. Goal of therapy needs to be predetermined by discussion with the patient and family at every single visit that we do. I mean, I do on the very first time, I said, here's the options. If this happened, this happened, this happened. So my patient usually do not get any surprises when they come to see me. And because they know what I will do if these are these are the findings on their restaging. Liver-directed therapy by interventional radiology or by surgery can bridge for a patient that needs control and cancer or disease control. Systemic therapy is guided by two principles, cancer or disease control and symptoms control. Those are the two things. You always ask yourself, if a patient has symptoms, is this control? If they have disease, is it control? Oftentimes, the therapy that you have will not provide both disease control and symptoms control. So targeted therapy, I'm very brief. I'm not going to spend a lot of time on this because it's just an overview. But targeted therapy has evolved in 3 areas, okay? Somatostatin receptor blockade, angiogenesis or anti-vascular blockade, and mTOR inhibition. Okay, so the study that is targeting somatostatin receptor subtype, the first one was the PROMID study. It was done to compare octreotide versus placebo for mid-gut neuroendocrine tumor. This is their study design. Just so you know, in case you don't read the literature, but I actually think that my patients are very savvy enough that they actually read all of their New England Journal papers and JCO paper. In fact, they never leave my clinic without having a paper in hand. So this is just the study design. So in the future, you can see this is the study group that we have. This is randomization, meaning they enter the system and they get randomized, meaning we don't have a control, whether they get this treatment or placebo, and then they get treatment until progression of disease. So this is a typical study design for many randomized study, okay? And the primary endpoint is time to tumor progression. The point here is that octreotide LAR slowed the progression in mid-gut neuroendocrine tumor. This is one of, actually it's the earliest randomized study that makes a difference in paradigm shifting of management. The other one is, the other study that is targeting somatostatin receptor is the LACNETS study comparing lanreotide versus placebo. However, this group of patients is actually inclusive of all gastroenteral pancreatic neuroendocrine tumor. Again, the same study design, lanreotide versus placebo, 1-to-1 randomization. The primary endpoint here is progression-free survival. I can spend a lot of time talking about statistics and what that means. At the end of the session. I think that will bore you. It won't make you faint, it will bore you, but I'm happy to talk about it. So progression-free survival was improved. So essentially the study was a positive study showing that the depot lanreotide extend progression-free survival in GEP-NET, getting FDA approval. So targeting angiogenesis, that's the other mechanism that has been explored, is the study with sunitinib versus placebo. This is a study that randomized patients between sunitinib versus placebo. And the primary endpoint, again, is progression-free survival. You wonder why is there no data on overall survival. It is very hard to do overall survival for neuroendocrine tumor, especially well-differentiated neuroendocrine tumor. And the reason is patient lives a long time, so study will last a long time, and it's very hard to follow them for a long time, but it needs to be done because the gold standard of any patient is whether it makes sense in overall survival. These are progression-free survival, okay? So the study showed that sunitinib significantly improved progression-free survival in pancreatic neuroendocrine tumor, getting FDA approval, 2011. The other pathway that is explored is targeting mTOR in that cells that I said. So we explored pathway that blocks somatostatin receptor subtype, angiogenesis, now mTOR. The study is a RADIANT-2 evaluating everolimus versus placebo in combination with octreotide LAR in mid-gut neuroendocrine tumor. So the primary endpoint is also progression-free survival. The study looks like it's separate. It's actually improved from 11.3 to 16.4 months. The problem is we know that it improved progression-free survival in mid-gut neuroendocrine tumor, but it did not meet its predetermined significance. Therefore, they did not move on to get FDA approval for this yet. So another study in a different group is pancreatic neuroendocrine tumor exploring targeting mTOR is the RADIANT-3, comparing everolimus versus placebo. Everolimus here is Afinitor. So patients were randomized to treatment versus no treatment. And the primary endpoint, again, is progression-free survival. The everolimus in this group of patients extend progression-free survival, getting FDA approval, again, in 2011. Okay, so here's the summary. The systemic treatment option of neuroendocrine tumor for disease control. In the past, this is what we have. For pancreatic neuroendocrine tumor, you have chemotherapy. For mid-gut, nothing. For disease control, I'm not talking about symptoms control, okay? Since 2009, this is what we have. We have more treatment option on the pancreatic neuroendocrine side, which is great for pancreas, we need to do better on the midgut neuroendocrine tumor. So in the future, I'm looking toward the midgut as having more treatment option because that's where we need to develop treatment. Not that we shouldn't develop for all neuroendocrine tumor, but we now have more choices. But what does that mean, more choices? More choices makes it very complicated for a regular community doctor to figure out what to give first, what's to give second, what happened, when do we say this is progressed and no longer usable and need to move on to treatment? For somebody who has treated this, we know that this is a course that you have to understand the natural history of disease to plan ahead. So having more treatment makes it a little bit more challenging. So going to see a site that has specialized in this, has multidisciplinary practice in this, is the way to go for getting treatment for neuroendocrine tumor, or at least optimal treatment for neuroendocrine tumor. So there is changing in landscape with more treatment option, especially in pancreatic neuroendocrine tumor. And actually, I think one of my big motto and awe-inspiring hero, not Dr. Yao, just kidding. He's actually a great senior partner and a very good mentor a lot of time. But Dr. Olberg said that there will be more treatment option than patient with neuroendocrine tumor. I challenge that, but I think that is a hopeful thought. If we have more treatment option, the cost of it will go down, and then you have more option that can prolong and change your course of life where you can have a normal life expectancy. So have we made a difference since 2009 or even since 1970? This is what Dr. Yao presented in ESMO, and I want to share it with you. This is showing a trend in improved overall survival for patients with pancreatic neuroendocrine tumor. This is from SEER database, from statistics, okay? In the period of 1970 to 80s, there's no treatment option, essentially. Median overall survival is 12 months. In the period of the 80s to the late 80s or the end of 80s, the median overall survival is improved to 20 months with the introduction of streptozotocin, which is an IV chemotherapy. In the era of the 1990s to the end of that, to 2000, with the introduction of octreotide, overall survival for pancreatic neuroendocrine tumor also went up to 25. And then with the introduction of octreotide LAR, this is improved 38 months for median overall survival. And most recently, with the introduction of TKIs such as the mTOR inhibitor and the angiogenesis inhibitor, the median overall survival has not been reached, but then we haven't followed them long enough. The bottom line here is we are making a difference in neuroendocrine tumor. It takes patient participation in clinical trial. It takes people dedicated to doing this. Okay, so take-home message, I won't conclude much, but there's a steady and persistent increase in incidence and prevalence, many classification system, grade, primary site, stage. If you don't remember anything at all, if you can ask your doctor what you have on these things, it helps a lot. And then the result of trials we have had changed the practice, improved overall survival, and the bottom line is that we have made a difference, especially in pancreatic neuroendocrine tumor. Thank you for your attention.